A 58-year-old female presents with severe, chronic pain, stiffness, and deformities in both hands and wrists. I am showing you posteroanterior and cone-down radiographs of the hands. Please describe the findings.
The hand radiograph demonstrates extensive, multi-joint arthropathy. In the interphalangeal joints, there are central erosions and marginal osteophytes producing a gull wing appearance. The wrist shows pancarpal joint narrowing and collapse, while the metacarpophalangeal joints show uniform narrowing and ulnar deviation.
What is your primary diagnostic concern?
The findings are diagnostic of coexistent erosive osteoarthritis in the interphalangeal joints and rheumatoid arthritis in the metacarpophalangeal joints and wrist.
What is the classic radiographic term for the interphalangeal joint deformities seen in erosive osteoarthritis? And how does it form?
This is the gull wing appearance. It is formed by a combination of central subchondral bone erosions or collapse, along with prominent marginal osteophytes at the joint margins.
How common is this clinical coexistence of rheumatoid arthritis and erosive osteoarthritis?
It is relatively uncommon but well documented. Approximately 15% of patients diagnosed with erosive osteoarthritis are found to have coexistent rheumatoid arthritis.
Which patient demographic is most commonly affected by erosive osteoarthritis?
Erosive osteoarthritis predominantly affects postmenopausal middle-aged to elderly women, typically presenting with acute inflammatory flares in the fingers.
What are the primary radiological features that distinguish rheumatoid arthritis from erosive osteoarthritis in the hands?
Rheumatoid arthritis features marginal erosions, symmetric uniform narrowing, and periarticular osteopenia, primarily in the MCP joints and wrist. Erosive osteoarthritis features central erosions, sclerosis, and osteophytes, primarily in the PIP and DIP joints.
What are the key differential diagnoses for this radiographic appearance?
The main differentials include psoriatic arthritis and chronic tophaceous gout. Psoriatic arthritis typically demonstrates distal predominance and fluffy periosteal new bone formation, which are absent here.
Finally, what are your clinical management recommendations?
I recommend referring the patient to a rheumatologist for systemic medical management. Treatment should include physical therapy, NSAIDs, and potentially disease-modifying antirheumatic drugs to target the rheumatoid component.